Hello and welcome, future doctors. I hope you're ready to deep dive into very important aspect, that is the recall of the FMGE January 2025 exam from the subject of general medicine. So this is the subject where I'm gonna break it down, simplify things before you, help you understand the tricky ones, because learning never stops, in my opinion. Simplify things before you. Okay. So, hi, I'm Dr. Marwah, your medicine faculty, and together we will explore these questions. I'll be providing smart solutions, pro tips, so that you can solve these ones. And drop your answers, drop your comments in the chat below so that I can get a fair about idea with respect to the options, whether the framing of the questions is right. Because in my opinion, the grind and the learning never stops till the dreams come true. And repeat my statement once again: the grind and the the hard work never stops till the dreams come true. So let me know the audio and the visual part is clear. And the pattern of the exam has always been something like American exam only. In fact, all exams are gonna be like this only, in my opinion, in future in India also. So this is a FMG festival. You can use the crack exam code in case you wish to. And yes, it is mental fatigue that comes in, guys. I do appreciate that. That's what I've been trying to inculcate in majority of my previous discussions, which were fairly long, about three and a half hours. And that is because we need to keep on hammering right till the very end, till the very last question is gonna be solved. So let's get started with the first one on the screen at the moment. This is Graham-Steele murmur is heard in which of the following condition? Waiting for your inputs for any modifications in the options. Meanwhile, guys, this question was, I think, only a one-liner. And the reason for this is pulmonary artery hypertension, because the high pressure in the pulmonary artery will cause incompetence of the pulmonic valve, and that would result in pulmonic regurgitation. Yeah, first section was, I agree. I mean, as far as your opinion is concerned, for the first part of the discussion or first part of the paper, it was much more challenging as compared to the second one. But this always keeps on happening. Like sometimes it's part one, sometimes it is part two, and they keep on oscillating between the two. Okay, so the options Rachit says are pretty straightforward. So the answer for this one is pulmonic regurgitation. As I said, the reason for this is pulmonary artery hypertension causing incompetence. And there are two names that they love to ask. One is Austin-Flint murmur of severe aortic regurgitation, and second is gonna be mild pulmonic regurgitation due to pulmonic, pulmonary. There was one option for pulmonic wall, but I think we are sorted as far as the concept behind the question is concerned, because in one liner it is like either we know it or we don't know it. So there are two classical names for benefit of those who might be watching it later. Austin-Flint for severe aortic regurgitation is what they've asked earlier, and then is Graham-Steele murmur for pulmonic regurgitation. And if one listens to the topic of murmurs, well, this is very much covered there. Okay, so okay, fine. Hyperthyroidism, I think, was a question later on. I'll just show you that question where there is gonna be a presence of pistol shot sounds that is gonna be auscultated over the femoral arteries. Great, Nitin. Yeah, doctor, I think Yogi, you are mistaking this question with a different question. I'll just show you that, abhi aayega vola, that pistol shot sounds and water hammer pulse. There, I think thyrotoxicosis was in one of the options. But as far as this one is concerned, we are sorted for pulmonary regurgitation as an answer. Okay, moving to the second one, this young man had recent onset palpitations and dizziness. Wanna know whether he mentioned alcoholic or any age group of the patient. The ECG shows absent P wave with irregular RR interval, which makes it atrial fibrillation. I also want to know the blood pressure values. Were they like more than 90 millimeters systolic? I got this value of 80/60, which is outrageously low, and that makes it me being ready for cardioversion as an answer. Okay, so yeah, rheumatic heart disease, we are coming. We are coming to rheumatic heart disease. Abhi aane wala hai bola question. So cardioversion, considering the blood pressure in the patient is less, the key words in the question would be absent P wave and irregular RR interval. Even in the sessions prior to this, LRR plus, we highlighted this. Atrial fibrillation is one of the commonest arrhythmia in our practice. That is why it is asked. Okay, this was a lady, and wow. Okay, great. So this was a lady, and there was no mention of any alcoholism, etc. But considering that rheumatic heart disease is common in India, it could be lady with rheumatic with mitral stenosis, which could have resulted in atrial fibrillation. So considering low blood pressure, the answer for this would be given as cardioversion. I would not like to go in for any of the remaining options because of the hemodynamic instability given in this question. Moving to the next one, Yeah, Yogi, that's a great input. Child presents with weakness of the lower half of the face with drooping of the angle of the mouth, as you can see on one side, and he's not able to raise his eyebrows, he's not able to close his eyes. So what you can notice on this side is a very characteristic weakness that is occurring. He's not able to, basically one half of the face is totally weak. So that makes it like a unilateral involvement of the seventh nerve, and that would be a lower motor neuron variety. So let me know if the image is like okay with or sync with whatever was present. Age was less. One of the options was Erb's palsy. Okay. Okay. Same question. Two questions from seventh nerve. One is from the anatomical perspective. Second is that hardcore general medicine perspective. What I want to know from you is, the image is fine. So one, we are sorted as far as the image is concerned. That is one I wanted to know, because otherwise, the entire perspective changes. If it's a different image, then it doesn't make sense. What I'm trying to highlight here is that forehead pay, there are no lines present, and the person is not able to close his eyes also on this particular side, and you can notice the drooping of the corners of the mouth also. So considering that, it will make it a lower motor neuron lesion, because one half of the face is involved in this particular case. So this would be a infranuclear fallacy on the left hand side. सुप्रान्यूक्लियर डॉक्टर, लाइक बच्चे में ना थोड़ा सुप्रान्यूक्लियर वाला इशू थोड़ा मतलब सोच के बोलना होता है, बिकॉज चाइल्ड हैविंग स्ट्रोक थोड़ा सा बच्चे, आई थिंक दैट वुड बी अ लिटिल अनलाइकली ना, cortico bulbar fiber the seventh nerve getting involved. So if I'm having like a stroke presentation and then I am thinking about supranuclear palsy, that would be, I would say, totally a little more, I would say, I'll be little afraid while answering this myself if I'm at your place, primarily because common diagnosis is the one which has to be answered. So yes, increased JVP with right ventricular hypertrophy. Okay, good. We'll just come to this. So I think this is the question that you are talking about. Yes, एक बड़े में था, एक छोटे में था. Yeah, Kasim, I get your point. So the one that is currently mentioned, I agree that this would be lower motor neuron paralysis as an answer. Okay. Yeah, left, not right, because right में बच्चे आंखें close कर रहा है ना. He is closing his eyes on the right hand side, right? But on the left hand side, is not able to close his eyes. Now, this is the side of weakness, because you cannot see any deviation. All you're seeing is drooping of the face on this particular side. So I understand confusion can be between left and right. And how do you solve it? On one side, you can see that he can close his eyes. So that means muscles are working fine. And the other side, there is a hypotonia due to lower motor neuron lesion. Now we come to that question of rheumatic heart disease, where there is presence of hyperdynamic precordium, and there was mention of water hammer pulse and pistol shot sounds. Here, I think one of the options was that of thyrotoxicosis. Uh, yeah. Both can be present. No? So MR, there is presence of MR as well as AR in the patient. Yeah, RST with rheumatic heart disease. Because of pansystolic murmur, I can say this would become mitral regurgitation. And because of the early diastolic murmur in this case, this would also become aortic regurgitation. But the predominant lesion in this patient are gonna be, okay, every option में दोनों थे. Okay, got it. Still, like I get the point. I can solve this question by pansystolic murmur and early diastolic murmur. That makes it a combination. So it would be like aortic regurgitation plus mitral regurgitation in a patient. Yes. Got it. Dr. Qasim Tayeb, I got your point. It was two combo lesions that were given, and the question can be solved on the basis of two aspects. One is gonna be the presence of water hammer pulse and pistol shot sounds. That makes it aortic regurgitation, and then there was a combo presentation as well. Okay, fine. So this is again sorted, like there could be various permutation combinations of various valvular lesion given. So yeah, rheumatic heart disease with mitral stenosis. Okay, fine, got it. Additional word that I'll add is rheumatic heart disease with AR with MR, rheumatic heart disease with mitral stenosis with mitral regurgitation. Like that, the multiple combinations were present. So I get the point. When we do a final version of this, then the combos are the ones which were given in this question. So point well taken. We are sorted for this one based on the logic that I mentioned, the murmur part. Okay. Then was a patient who underwent a cholecystectomy. Let me know whether this was a child from some state like Odisha or central part of India or tribal India. If it was mentioned, it will help in diagnosis. And there were black pigmented gallstones which were noticed. So black pigmented gallstones basically tells us that this would be a hemolytic anemia, and all the options are those of hemoglobinopathies only. But then there is that one keyword in the question which is mentioning that he's having shortness of breath and chest pain during hospitalization, which has occurred multiple times, which is telling us regarding, okay, it was beta thal major, okay, beta thal minor. Okay, got it. So one option of beta thal minor, I can say, would not be an answer because beta thal minor usually remains asymptomatic. No, this is going to be a trait, so it never becomes symptomatic. And yeah, because of chest pain, because there was manifestation of acute chest syndrome in this patient. Acute chest syndrome implies sickling crisis is given because of the sticky red blood cells. So that should be okay. Yes, Ishan, this is an interesting one. It is to be ruled out. Okay. Okay, which is least likely to cause. Okay. Okay, so this was a not question. Fine. Let me know the options. One is G6PD, beta thalassemia. I think it would be going in favor of whatever is the diagnosis, or it can be which of the following can be ruled out. Okay, least likely as an answer. Fine. So it is beta thalassemia minor would then become the answer, guys, because it's a trait ना फिर तो वो हो ही नहीं सकता ना. All other are having hemolytic anemia present. So hemolytic anemia, I mean, if you say beta thalassemia minor is present, then beta thalassemia minor में कभी symptoms नहीं होते. Got it, Dr. Rizvi. That was again an interesting input that you provided. So I'll say it like this. In case he says like what is the cause of this presentation, we'll go in case of sickle cell anemia. But if it's gonna be like if I have to rule out among all these options, then the least likely possibility in this case would be a beta thalassemia minor. Considering that it is not given, therefore I would like to base my answer as beta thalassemia minor in this question. Let me know any other options to be changes. Hemoglobin Punjab, beta thalassemia minor, G6PD, and then is sickle cell anemia. Actually, some guys were very vocal about this H being present in a question. That is why I wanted to know if you are like, maybe mixing up the two, and that could be the reason why we are like changing the answer to this question. Otherwise, the initial look of this question was like, what is gonna be the cause of the disease? Any inputs with respect to any changes in options, especially option number A that you would like to change that hemoglobin Punjab, because I got HP hemoglobin Punjab and hemoglobin H also. Hemoglobin H is a manifestation of alpha thalassemia. Okay, so the final conclusion is, guys, if he says what is the cause, then it would be sickle. If he says what is unlikely the cause, then the answer would be given as beta thalassemia trait for this one. Moving to the next one, we have a patient coming in the emergency room with pain on the left side of the chest radiating to the left arm and shoulder for 40 minutes. Let me know about the duration part, whether it was 20 minutes, 15 minutes. Duration will not change. I'm just trying to be accurate. I mean, the diagnosis is based on ST segment depression, and patient is having chest pain at the moment, which is present at rest, though it does not mention the word rest. So considering ST depression, the clinical diagnosis of this patient would be unstable angina or non-ST elevation MI. And for all of these patients, one of the initial approaches that I need to go ahead is use dual antiplatelet therapy, that is DAPT. I would like a feedback from you guys with respect to the duration of chest pain, if there is any fluctuations in that. And second, with respect to whether these words like low dose, loading dose was given. In all patients of acute coronary syndrome, generally, if I say it like this, any case of acute coronary syndrome, it's a DAPT, dual antiplatelet therapy that would be used. So we'll be giving aspirin and clopidogrel for management of these patients. We do not do thrombolysis, so that's ruled out. Stress test would be done in patients of stable angina. If we mentioned chest pain that is getting relieved on rest and it's recurrent episodes, but considering ER presentation, a person of like chest pain resolving by itself is not going to come to the emergency room. Okay, so the correct answer for this one is option number B. And throw in your comments with respect to whether the word low dose or loading or anything like that was given or not. Otherwise, the answer does not change. Even if I remove those words, I mean, it does not change the real perspective. Okay, troponin elevated was given. Fine. Troponin elevated. So troponin elevation makes it non-ST elevation MI as a diagnosis. Okay, there was nothing like a low dose. There was nothing like a loading given. Fine, doctor. The answer still remains the same, dual antiplatelet therapy. I mean, first thing that we do in acute coronary syndrome is because there's a clot that is developing, there's a platelet plug being formed. So I want to inhibit the formation of the platelet plug, and that is why we will have to give dual antiplatelet therapy for these patients. Okay, duration was 20 minutes. Okay. Stress test and thrombolysis. Okay. Aspirin and discharge. Okay, so that would not be a correct way to handle the case. Thrombolysis would not be done. Okay, fine. Doc, even if it is relieved in rest, the troponin I elevation will change everything ना, क्योंकि अगर आप बोल रहे हो कि troponin I दे रखा है elevation में, तो फिर तो it is gonna be myocardial infarction ना, then we cannot say chronic stable angina. The point against is, even if you say chest pain is relieved on rest, still ultimately because biomarker is elevated, so it's gonna be, maybe he was given medication, right? So that could have resulted in improvement of the chest pain in this patient. Okay, aspirin, clopidogrel. Maybe Keshav, if you can mention regarding maybe heparin, I can give options here: enoxaparin, statin, ACE inhibitor. Yeah, we will treat as myocardial infarction, absolutely, because troponin I is elevated, ST depression is present, so that's acute coronary syndrome, and dual antibiotic therapy would be given in this patient. Okay, so let me just dissect the options before you try to simplify this. I'll not send the patient back home of myocardial infarction. Thrombolysis is not done in non-ST elevation MI. That is why it is ruled out. So two options are going out of the window in the first read itself. And as far as performing stress test is concerned, that would be like, once I've recovered the patient in acute stage myocardial infarction, doing a stress test would not be. Okay, fine, guys. I think we can continue debating this, but the final solution is, for any case of acute coronary syndrome, whatever be the type of MI, it is, dual antibiotic therapy is the next best step to be given anyway. Like, he did not even get into the specifics of the treatment. It was just like, what will you do in the initial case? Fine. Then is regarding first degree heart block. Let me know if the options are correct and then I'll solve it for you. First degree heart block is a problem between the connection between the SI node and the AV node. It occurs in like rheumatic fever, uh, endomyocardial fibrosis. It can be occurring in sarcoidosis. Like, there are non-causating granulomas or sarcoidosis that could be slowing down the conduction. So there would be a prolonged PR interval and a normal RR. Okay, so fine. I think the options are correct. There were combinations given of PR and RR interval, and the correct answer for this one will work out to option number B. Okay, prolonged PR interval and each P followed by R. Okay. Each P followed by normal QRS. Got it. Each P followed by a normal QRS. No, that is a separate question on Mobets one, no? So, hi Raj, good to hear from you. Prolonged PR interval, and then there's going to be normal RR interval, and each P followed by QRS. So that makes sense, guys. No, Vishwajit, you are mixing it with the next question. That is drop वाला ना, अभी वो drop वाला दिखाता हूँ मैं. That is Mobitz one heart block, क्योंकि वो I think आप दोनों mix कर रहे हो. So they give QRS explanation. I get it. With respect to first, I'll just show this question once again. First degree heart block is problem between the SN node and the AV node, and the conduction in this case is slow. So the only thing that happens is PR interval will be more than 200 milliseconds. That's the only thing that happens, and therefore you would be having a normal RR, and there would be like each P followed by a normal QRS. And the second question was on Mobitz one heart block, in which there is gonna be a gradual prolongation of PR followed by missed beats. So yes, then is gonna be Mobitz one. Okay. Okay, fine. So there was a single question on heart block. I doubt it. People were very vocal about, one is first degree heart block. क्योंकि दो अलग, अच्छा आप उससे confuse हो रहे हैं. First degree heart block and Mobitz one heart block से. Okay, get it. But Mobitz one is second degree ना actually. Mobitz one is second degree heart block and a drop beat present. Okay, fine. वो मिस्ट की जगह पे ड्रॉप कर देते हैं ना, मिस्ट की जगह पे ड्रॉप बीट कर देते हैं. तो दो अलग अलग क्वेश्चंस थे बच्चे. आई थिंक वन इज फर्स्ट डिग्री हार्ट ब्लॉक, सेकंड इज Mobitz one heart block. Mobitz one heart block is a variety of second degree heart block, and you have a gradual PR interval, increase, then there is a drop beat occurring in a person, whereas in Mobitz it's like normal, and then you get drop beats in a person. So I think yes, there were two questions, and the correct answer for this one is option number A. The basic point is, in Mobitz one heart block, where is the problem? It is inside the AV node. No, this is like intranodal defect. इंट्रानोडल मतलब जो एवी नोड है ना, वो तो वैसे ही स्लोली कंडक्टिंग होता है. देन दिस वुड बी एग्जिबिटिंग अ इवन स्लो कंडक्शन. सो दिस वुड बी अ इंटरनोडल कंडक्शन डिफेक्ट दैट वुड बी रिस्पॉन्सिबल फॉर द ग्रेजुअल प्रोलॉन्गेशन ऑफ पीआर फॉलोड बाय दिस वन. Okay, doc. If Mobitz one was not present, then it is like first degree heart block. So I've handled both of them. Whatever be the scenarios, whatever you say, if you found question which is having first degree heart block, your answer would be prolonged PR interval. Okay, Richpal, thank you for the input. I'll go by first one. I mean, this is what I think was usually asked because this question came in NEET PG also, though in a different way. वहाँ तो सिर्फ duration पूछ के छोड़ दिया. आप वाले में थोड़ा सा tricky कर दिया, and it was like each P followed by QRS, and he might have mentioned some drops in the options as well. Okay, fine, fine. Drop. Parveen, I get it. I get it. I get it. So in this question only, the drops were also mentioned, and there are no drops occurring in first degree heart block. That's the point to be remembered. There is no drops which are present in first degree heart block. Okay. So answer to this is option number B, and we now move to another one where person, I think here JVP was also mentioned. Patient presents with progressive increase in yes, Mohit, your answer is correct. It is normal PR with normal RR interval, and there are no drops present in first degree heart block. The drops would be occurring only with respect to either Mobitz 1 or with respect to Mobitz 2. Okay. Next was a question with respect to increasing shortness of breath. I think this was the key word in the question. Left parasternal heave is noted with a palpable liver. Maybe mentioned something with respect to elevated JVP in this condition, which is giving me evidence of the fact that the right side of the heart is getting involved. And there was a systolic murmur that was also present. So that makes it as pulmonary artery hypertension. Yes, it would be loud P2 to be specific. If he gives me information of loud S2, that again gives credibility to the diagnosis of this patient. Of a sound of a third given. Okay, that's a good one. That's a good one. So female patient, fine. So a female patient with shortness of breath, then there's a left parasternal heave. That tells you about right ventricular hypertrophy, because if there's pulmonary artery hypertension, there would be right ventricular hypertrophy. This is going to contribute to parasternal heave. And the pulmonary artery hypertension, the pressure will cause the P2 to close with more force. So there would be loud P2 or loud S2 or maybe a third described in a question. So I think all those pointers are going in the same way. I'll say the reason again: high pressure in pulmonary artery will धक्का मारेगा पीछे से valve को, so it's going to contribute to a loud P2, loud S2, or a third that could be described in a question. Yeah, Shivansh, the Graham steel murmur part we have already sorted out in the earlier part, but so this time he took fancy to the pulmonary word. I mean, a lot of questions with that. Okay, so the point is the description was like a loud sound that is present. Considering that, we'll say pulmonary artery hypertension. What is the reason for systolic murmur? In all cases of right ventricular hypertrophy or right ventricular failure, subsequently they can be tricuspid regurgitation, which is called as a functional one. So the explanation for the systolic murmur is a functional, because right ventricle dilate ho jayega, the tricuspid annulus in the person would also be affected. Okay, okay. Patient on medication. And then there is progressive shortening of breath. So progressive in spite of medications, and still there is worsening. That again goes in favor of pulmonary artery hypertension because it's a nasty disease to be given. Okay, SAG pay we are coming, and AKI I'm coming. Exploring world, so just hold on to there. Pregnancy may, okay, pregnancy will be loud S1, doc. It would be loud S1 in pregnancy. And then there was a question on mitral stenosis की severity को कैसे determine करते हैं. I'll come to that question in a while. The next one was regarding mitral regurgitation. Patient is having shortness of breath and there is a perihalar highness in a patient. So every time we have this mitral regurgitation, you would be having blood leaking from the LV to LA. This is going to cause congestion in the left atria. The congestion in the left atria would then contribute to congestion in the pulmonary circuit also. So that explains the pulmonary edema component, which is occurring in this case. And narrows down the diagnosis to this patient was like cardiogenic. Okay. Cardiogenic acute pulmonary edema. Option number A is non-cardiogenic pulmonary edema. So this would be like cardiogenic pulmonary edema. Yep. Great. Great. Image was there. Image का बताना मुझे एक बारी. Was any image in this question given? Okay, X-ray was given. Okay, so X-ray showing a bat wing edema was given in this patient. ठीक है. Fine, I'll mention that. That's a pure cardiogenic pulmonary edema. Fine, guys. I think you were very quick to pick it up, so we don't need to debate this more. I mean, cor pulmonaris pulmonary embolism, ARDS की जगह non-cardiogenic pulmonary edema होगा. इससे ज़्यादा यही होगा. Hazy edematous X-ray bilateral image. Okay. Fine, guys. I get the point, and I think we are sorted for this answer as option number B. Okay. Then was a question on meningitis. I want to share the values with you. I think 90% neutrophils in turbid CSF. The protein was about 200. Let me know if the values are right and we can move. Yeah, ascites question I'm just coming to, doctor. SAG, serum albumin ascites gradient one. Okay, so this was, I think, pyogenic meningitis only. And considering pyogenic meningitis, because pneumococcus is the organism, so we give two antibiotics, ceftriaxone and vancomycin, because nowadays the pneumococcus could have become resistant to ceftriaxone also. So the answer for this would be option number B. Yeah, ceftriaxone, vancomycin, both of them. Okay, cool. So I think this was a pretty easy one. The last option was okay, 80 to 90% will not change the answer okay. ओके, ये एम्पिसिलिन का थोड़ा रिफाइन कर दो मुझे, एंटीबायोटिक बता देना कौन सा था सिफोटैक्सिन के साथ में कौन सा. वन वाज एच आर जेड ई, लाइक ही डिड नॉट राइट एंटी ट्यूबरकुलर ट्रीटमेंट, आई थिंक ही रोट एच आर जेड ई सेपरेटली. या क्रिप्टोकोकस डॉक, दैट्स वेरी सिंपल, यू नो दैट हैज ऑलरेडी बीन डिस्कस्ड. वो तो इतना मतलब सब डिस्कस कर चुके हैं, तो आई एम ट्राइंग टू डिस्कस दोज विच मे माइट हैव नॉट बीन कवर्ड, राइट. That cryptococcal meningitis, the treatment, anyway, since you wrote it, I'll just mention it here because I saw that answer somewhere was given as for cryptococcal meningitis as liposomal amphotericin B plus fluconazole. It is not fluconazole, guys, it is flucytosine. So I'll just clarify that. I saw somewhere that it was mentioned as liposomal amphotericin B and fluconazole. It's 5-flucytosine. Okay, ampho B. Okay, got it. Fine, doc. I think we are sorted for this one. Pyogenic meningitis with ceftriaxone with vancomycin. And yeah, one option was fluconazole. That is what I'm trying to say. No, fluconazole is given subsequently. Yes, a different question on fluconazole. And the question was like, how would you manage cryptococcal meningitis? So that has already been discussed, I think, in pharmacology. Okay. So we are having all the arrows going up, 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 and you know that if all arrows go up, 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 that would be metabolic alkalosis. Plus there was vomiting also described, so pretty straightforward one. There was no aspect of mentioning with respect to whether there is gonna be any, compensated, partially compensated, fully compensated. उसमें गया ही नहीं, वो सीधा सीधा डायरेक्शन वाला जो वैल्यूज है उसी को पूछ लिया. Yeah, happy Makar Sankranti to everybody. Let's move on to the next one. It has always been like this only. Every time the paper is like people are always worried about the exam pattern being difficult. It's like this only for all the years, and for like there can be like a little bit of ups and downs. I agree for that. Some subjects can be a little more intensively grilled, but overall, I think like sometimes they go overboard with it, but you can still pick up those easy ones in the discussion. Okay, so fracture of shaft of femur, breathing difficulty. One option was pulmonary edema. Can you clarify this one? Was it pulmonary edema? Was it pulmonary embolism? I agree. Like, this is going to be fat embolism syndrome. I agree to the answer in this case. Okay, fracture of tibia as well as femur both. Okay, okay, fine, fine, fine. Yes. Yeah, it was pulmonary edema. It was not pulmonary embolism. I checked with a lot of people, and you can see that yeah, pulmonary embolism was not in the options because see, one is talking about multiple bone trauma, he's talking about breathing difficulty. So we need to give credibility to that. I just wanted to check out whether he put it up as pulmonary embolism also, because if a person is immobilized for long duration, there can be possibility of even pulmonary embolism also. But suppose it is pulmonary embolism, then he has to give you findings of right ventricular failure. So if the question mentions elevated JVP, if he mentions regarding presence of a wide split second heart sound, then it is okay. But otherwise, like I cannot say that, no? Yeah, Shubham, even if it is pulmonary embolism, ना right ventricle failure के findings दे होने चाहिए ना. Right ventricle failure होगा तो jugular venous pressure बढ़ जाएगा. Right ventricle failure होगा तो blood lungs में कम जाएगा, तो BP कम हो जाएगा. तो वो फिर he then should mention regarding those findings of right ventricular failure only, ना. Only a drop in SpO2. Okay. Rapid drop of SpO2. Great. But TK was mentioned in the question, polytrauma and fat. Yeah, we are over diagnosing now. We are trying to over diagnose things now. Okay, Petike was given, that makes it easier, doctor. If he has given Petike, cool. I wanted to know if Petike were given or not. But if Petike are given, then it is fat embolism only. Fine, guys, with Petike, fat embolism as the final. Okay. ARDS तो बच्चे चेस्ट ट्रॉमा में होता है ना, लाइक फॉर सेइंग ARDS, लाइक ARDS का कारण तो निमोनिया होता है, ARDS तो ट्रॉमा चेस्ट ट्रॉमा पल्मरी कंट्यूजन में होता है ना, ये तो फ्रैक्चर होता है, तो शाफ्ट एंड फीमर है, तो इसलिए ARDS नहीं होगा ना. ओके. Even if no petike, doctor, even if no petike given, even then I think there has to be some evidence of right ventricular failure occurring in a pulmonary embolism में तो एकदम से BP क्रैश कर जाएगा ना यार, तो he should mention hypotension, he should mention elevated JVP because lungs में blood ही नहीं जा रहा है, तो he has to mention something related to crashing of blood pressure. If there's no mention of crashing of blood pressure, then it gives in presence of fat embolism as a diagnosis. Okay, the next one is a child having muscle weakness. One, I want to know whether it was child or adult. There is like muscle weakness, and then there was metabolic alkalosis with hypotension. Was it metabolic alkalosis with hypertension, or was it metabolic alkalosis with hypotension? That's the first thing that I want to know. Yes, doctor, that's what I want to know from you. Is it Conn syndrome with hypotension? Very, very unlikely, na? It is very unlikely that you will have metabolic alkalosis. Yeah, child with polyuria, polydipsia, and weight loss. Okay, child and a hypotension. Agreed. Okay. Mm-hmm. Okay. I'll explain the polyuria and the polydipsia component also in this case. The reason for polyuria and polydipsia is salt wasting, na? Because the syndromes that we will discuss here, they are the ones which are responsible for this. Yeah, child is malnourished also. Fine. 6 months पे malnourishment तो नहीं बोलते बच्चे. Then we call it failure to thrive. We call it failure to thrive. ओके. चलो मैं कॉन सिंड्रोम बताता हूँ. कॉन सिंड्रोम में क्या होगा कि पर्सन को हाइपरटेंशन होती है, और हाइपरटेंशन के साथ में मेटाबॉलिक एल्कोलोसिस होता है और हाइपोकलीमिया होता है. तो इस क्वेश्चन में अगर हाइपरटेंशन नहीं था तो इट इज़ अनलाइकली कि कॉन्स होगा. और 6 महीने के बच्चे में कॉन सिंड्रोम होना, थोड़ा सा ट्यूमर्स तो ओल्डर एज ग्रुप में ज़्यादा कॉमन होते हैं ना. सो दैट इज़ द पॉइंट दैट आई एम ट्राइंग टू आस्क राइट नाउ एट द मोमेंट. दैट इज गोना बी या फेलियर टू थ्राइव डिस्क्राइब्ड इन अ क्वेश्चन. अब वही तो पॉइंट बोल रहा हूँ ना मैं. द आंसर इज नॉट कॉन सिंड्रोम बच्चे. द रीजन फॉर दैट इज कॉन सिंड्रोम विल कॉज हाइपरटेंशन, इट विल कॉज hypokalemia, agreed, but it will cause high blood pressure. If the BP is low, then we have to think in terms of two disorders of the kidney tubules, Bartter and Gitelman syndrome in a patient, and both of them contribute to metabolic alkalosis, क्योंकि दोनों में tubular defects होते हैं ना, तो salt का loss होता रहता है. और क्योंकि टिब्यूल्स का डिफेक्ट है तो इस वजह से सॉल्ट वेस्टिंग इनमें होती है, तो सॉल्ट का लॉस होगा तो पानी का भी लॉस होगा. एंड बिकॉज ऑफ सॉल्ट एंड वाटर लॉस फ्रॉम द बॉडी, दैट इज वाई देर इज लाइक पॉलीयूरिया एंड पॉलीडिप्सिया प्रेजेंट इन दिस केस विद फेलियर टू थ्राइव. वेट भी कम हो रहा है कि शरीर से पानी निकल गया ना इस बच्चे के. अब जो मेन डायग्नोसिस है दैट वुड बी बेस्ड ऑन इलेक्ट्रोलाइट इम्बैलेंस. दैट जो की वर्ड था विच विल डिसाइड द आंसर इज व्हाट इज द इलेक्ट्रोलाइट इम्बैलेंस गिवन इन द क्वेश्चन. द इलेक्ट्रोलाइट इम्बैलेंस गिवन इन द क्वेश्चन इज दैट ऑफ I would say 24-hour urinary calcium is more, then we will say Bartter syndrome. And if it is going to be hypomagnesemia, then it will be Gitelman syndrome. The answer for this is, guys, not Conn syndrome, because Conn syndrome has hypertension with alkalosis. The correct answer for this one will be worked out to Gitelman syndrome. Okay, one option was Dent's disease. Okay, fine. I get the point, doctor. Dent's disease would be having, again, calcium loss in the urine. Okay. ओके, सो इवन इफ मैग्नीशियम, ओके चलो इसको रूल आउट करते हैं. मैग्नीशियम इज नॉट गिवन. देन बार्टर सिंड्रोम जो होता है ना, उसकी यूजुअल प्रेजेंटेशन होती है राइट एट बर्थ. इट प्रेजेंट्स विद राइट एट बर्थ. एंड बार्टर सिंड्रोम यूजुअली विल बी हैविंग, आई मीन ब्लड प्रेशर इन बार्टर सिंड्रोम इज यूजुअली टुवर्ड्स द नॉर्मल साइड. हियर द ब्लड प्रेशर इज गिवन ऑन द लोअर साइड. सो वी हैव टू थिंक एज लाइक Gitelman versus Bartter syndrome. And one is Dent's disease, that is like again 24-hour urinary calcium would be elevated. Okay, hypochloremia. Okay, fine, fine, fine. Fine, got it, doctor. Yeah, they can be two different questions. Maybe one they mentioned about Conn syndrome, but here, like considering hypotension, I'd not go with Conn syndrome at any point of time. Okay. So let me know, guys, in this question, was there any mention apart from chloride values, anything else with respect to calcium that is described? Because 24-hour urinary calcium values, I just want to know if they were given in a question. That will favor the diagnosis of what you guys are saying. Then Bartter is where the 24-hour urinary calcium would be elevated, and you would be having like nephrocalcinosis in a patient. Okay, Kasim, that is an interesting point. Hearing loss is present in the case. Uh, give me a answer in this case, guys. Any hearing loss present in this case also? The child has hearing loss. Yeah, doctor. Still, Gentleman syndrome as the first differential diagnosis in this case. चलो मैं रिजॉल्व करता हूँ. सपोज मैग्नीशियम भी नहीं दिया हुआ, हियरिंग लॉस दिया हुआ है. अगर हियरिंग लॉस है तो हम बोलेंगे बार्टर सिंड्रोम एज अ पॉसिबिलिटी, कि बार्टर सिंड्रोम में क्लोराइड डिफेक्ट होता है ना, जो कि इनर सेल्स के साथ, इनर हियर सेल्स के साथ रिलेटेड होता है. तो कंसिडरिंग द फैक्ट दैट इन दिस क्वेश्चन इफ देयर वाज एनी मेंशन ऑफ एनी सेंसोरी न्यूरल हियरिंग लॉस, आई विल आंसर दिस एज बार्टर सिंड्रोम. And in case this question mentions regarding hypomagnesemia, hypochloremia, then I'll answer this as possibility of Gentleman syndrome in a patient. But this would not be answered as cons, and was one of the very tricky ones. I can understand and appreciate that in a limited time frame that you have at your disposal, it becomes really a difficult one to handle. Okay, so I think we can move to a easier one at the moment where a smoker has come, and this time like I can expect quicker answers therefore. Congenital rubella, doctor, I think has been taken care in pediatrics. There was a patent ductus arteriosus continuous murmur given with cataract, so that's why I did not include that in this particular question. Smoker with a low FEV1 would be COPD. That would be answer number A for this one. Yep. And then there is again vomiting question. I think they went after vomiting this time without ABG report. This lady is having bulimia, that is binge eating followed by mouth mein finger dal ke they are causing vomiting. So that would be metabolic alkalosis. D is not in the options. D squamative. Okay, okay. Yogi, can you let me know the option for D in case this time mentioned? Long time smoker. Okay. Okay, इसमें electrolyte पूछा था. Fine. So electrolytes in this case would be hyponatremia, hypokalemia, and hypochloremia. Yeah, if there are electrolytes, then there are three: hyponatremia, hypokalemia, and hypochloremia. Three things would be happening in this patient. Yeah, yeah. Hypokalemia is the predominant one with hypochloremia. Okay, bronchogenic carcinoma. Fine, got it. एस्थमा की जगह पे भी अगर कोई ऑप्शन ऑल्टरनेटिवली आ रहा है, गुड एंड हैप्पी थॉट्स, तो मेंशन कर देना. Laxatives, diarrhea, vomiting, electrolyte imbalance. Doc, every time there is like Shubham, that's a good input you provided. I'll include that in my final round of questions. But considering that it is like diarrhea, vomiting, then first electrolyte imbalance that would set in is hypokalemia. As long as there's no kidney injury. Once kidney injury will occur due to dehydration, then reverse will happen, hyperkalemia. But usually by diarrhea, like we get hypokalemia as a presentation. Okay, fine. Silicosis. So guys, the remaining things would be like B and D will be going in favor of occupational lung disease, and the FEV1 FVC ratio should be going towards 0.8 in the question. No? I think we're mixing two questions. One is young female with vomiting and is asking regarding electrolyte imbalance. That would be hypokalemia, metabolic alkalosis, and the remaining aspects that I said. Second is like the second one that you had mentioned. Okay, moving to the next one, which was a straightforward one. This I don't think so requires any debate. The question said viral infection 2 weeks back, and then there is this ascending symmetrical flaccid paralysis occurring in this patient. Uh, yeah, English is typically British English. That's the problem, man. That's the problem. Like if they put it in simple words, it becomes okay. The English is used like the one that's given in an Harrison. It's typical that British English, which is difficult to comprehend, which causes errors of judgment. This one, Mohit, viral infection 2 weeks back and symmetrical paralysis. This is Guillain-Barré syndrome, no? Bilateral symmetrical bladder spared. Okay, bladder was spared. Yes, bowel and bladder spared. So yeah, if bladder is spared, भाई लोअर मोटर ब्लैडर एंड बबल स्पेड पे तो मैं वहां तक तो मैं पहुंच ही नहीं रहा हूँ. मैं तो सिर्फ ये बोल रहा हूँ कि अगर किसी को पहले वायरल इन्फेक्शन है जीका वायरस का या Campylobacter jejuni और उसके 2 weeks के बाद में there is like a bilaterally symmetrical lower limb paralysis progressing over the next couple of weeks. So lower motor neuron lesion है ना. So we'll answer this as option number A, acute inflammatory demyelinating polyneuropathy, which is other name for Guillain-Barré syndrome in the question. Atrial fibrillation, we use drugs, no? Atrial fibrillation, we use drugs, but ultimately blood pressure is low. You'll have to anyway manage the patient, no? First you go for rate control, then anticoagulation, then chemical cardioversion and electrical cardioversion in a patient, no? So electrical cardioversion is to begin if there is an acute onset atrial fibrillation. That was a good joke. ILTS band 9. Multiple sclerosis बच्चे brain का involvement होगा, so that was upper motor neuron lesion. Amyotrophic lateral sclerosis was upper and lower motor का combination. So considering the patient is having pure lower motor neuron paralysis, the answer would be given as okay, किसी और नहीं बोला transverse myelitis. Okay, so that is idiopathic transverse myelitis again. Transverse myelitis में bladder and bubble involved होता है ना. Transverse myelitis has a characteristic of involvement of the urinary bladder. Lower motor neuron manifestations in transverse myelitis can occur at the level, but below that is again upper motor ke manifestations. Okay, Stephen Hawking's disease. Okay, fine guys. We are sorted for this one. Let's move on to the next question. In a patient with electrical burns and stable vital signs, there is red color urine that is being obtained in an individual. So red color urine is telling me that this guy is having myoglobinuria. I've explained to you that red color urine does not mean RBCs or does not mean blood. It means myoglobin in the urine. And the reason for that is electrical burns could have caused muscle necrosis. So this question is on rhabdomyolysis. Okay, there was a photo in this question also. Okay, Priyanka, I'll be able to address this at a subsequent part of time. At this moment, let's just sort out this question. But I get the point. Where will you look for the spleen, accessory spleens in a patient? Okay, picture of urine was given. Okay, so there was an image of red color urine that is described in this patient. Creatinine kinase was elevated. Okay, bilirubin in the options. Okay, bilirubin कर लेते हैं. I mean, I can mention one as increased bilirubin, like I can incorporate that. Okay, increased bilirubin, and that anyway will not be the answer. I get your point. It may not be potassium. Okay, fine. चलो इसको वर्कआउट करते हैं यार. बेसिकली होने क्या वाला है कि मायोग्लोबिन इज गोना कॉज ब्लॉकेज ऑफ द किडनी ट्यूब्यूल्स, नो, एंड मायोग्लोबिन विल ब्लॉक द ट्यूब्यूल्स ऑफ द किडनी. इट विल कॉज acute tubular necrosis, and acute tubular necrosis will be causing serum creatinine in the patient to rise. So the red color urine in this case is not indicating any hematuria. It is indicating rhabdomyolysis. Myoglobin is going to be contributing to this. So that is why, yeah, creatinine kinase is also elevated. That is because of the destruction of the muscle, no. Okay, increased creatinine kinase. I can incorporate that. Increase CK levels also in the options. Fine. हाँ, मुझे बस इतना बता देना कि क्रिएटिनिन था कि नहीं, तो ऑप्शंस में फिर आगे बात करते हैं. मतलब आई एग्री टू द फैक्ट. मैंने हटा दिया यार इसको. आपने जैसे बोला ना, मैंने हेमोग्लोबिन भी हटा दिया, एंड मैंने आई हैव इवन रिमूव्ड द पोटेशियम थिंग देयर. All I'm asking is whether there was creatinine given in the question. No, increase RBC नहीं है. Increase RBC is not the answer. Let me just resolve it there. Yes. So acute tubular necrosis होगा तो creatinine will rise in the patient. Okay, increase unconjugated bilirubin. Hemolysis नहीं हो रहा ना यार. It is basically kidney failure that is occurring. It is myoglobinuria that was mentioned. So I get the point. Creatinine kinase बच्चे है, but creatinine kinase तो मसल इंजरी के लिए यूज करते हैं ना. मतलब आप स्केलेटल मसल इंजरी के लिए यूज करते हैं. लेकिन जो अगर क्रिएटिनिन क्लियरेंस है तो पहले तो हम क्रिएटिनिन के साथ करेंगे ना, बिकॉज द पर्सनस यूरिन इज आल्सो डिस्क्राइब्ड. सो पर्सन इज एट द रिस्क ऑफ रीनल फेलियर. सो the test I will do is like creatinine kinase will not help me in arriving at diagnosis of rhabdomyolysis. In fact, I'll just correct the spelling also. Just serum creatinine, only checking CK would not be helping me in arriving at a diagnosis of this patient. I also need to check out whether the kidney in the patient is getting affected. So if I don't have creatinine in the options, if I did not have creatinine in the options, then okay, I can say CK as the correct answer considering. Okay, fine. Shubham, I take your point. हाँ, यूरिन रेड का रीजन क्या है? यूरिन रेड का रीजन क्या है? तो देन यूरिन रेड का रीजन है रैप्डोमायोलाइसिस। तो मसल्स के डिस्ट्रक्शन का एविडेंस क्या होता है? तो क्रिएटिनिन काइनेस होता है, right? So there are two things in this question that we are debating. I'll resolve it for convenience of everybody. In all patients who are having रेड कलर का यूरिन क्यों आ रहा है, वो उसके ऊपर येलो कलर का बबल था, वो तो हो सकता है, बट लाल यूरिन अगर आ रहा है तो मतलब मायोग्लोबिन आ रहा है मसल में। और अगर मायोग्लोबिन मसल में आ रहा है तो मसल के डिस्ट्रक्शन का एविडेंस भी होगा और साथ में रीनल फेलियर भी हो जाएगा। तो अगर रीनल फेलियर के परस्पेक्टिव से है तो आई विल से इंक्रीज क्रिएटिनिन। दैट्स द फर्स्ट थॉट प्रोसेस ऑफ माइंड। In case he did not have that serum creatine options, not an issue, then your answer of creatine kinase CKMM values being elevated, that is perfectly spot on for this particular case. Okay, fine. No, it is not super confusing here. Rhabdomyolysis ला पहली कंसेप्ट ही यही है। मोस्ट पीपल आर नॉट, ये रेड कलर यूरिन पढ़ के मोस्टली लोगों ने तो आप जो आंसर किया है रेड कलर यूरिन पे, वो तो आरबीसीज के परस्पेक्टिव से है, जबकि रेड कलर यूरिन मायोग्लोबिन यूरिया के साथ होता है ना, बस इतना ही कॉन्सेप्ट है सिंपली। और अगर मायोग्लोबिन यूरिया होगा तो एक्यूट ट्यूबुलर नेक्रोसिस होता है। Midstream sample, Priyanka. Midstream sample is the method of collection for sample. Midstream flow is how do we collect the sample there. Okay. क्रिएटिनिन काइनेस नहीं, क्रिएटिन काइनेस है ना। इट्स नॉट क्रिएटिनिन, इट इज क्रिएटिन काइनेस। दैट्स अ टोटली सेपरेट थिंग। क्रिएटिनिन नहीं है, इट्स क्रिएटिन काइनेस। ओके। Okay, Popeye the Salesman, that was a good option there. A patient has been diagnosed with mitral stenosis. What is the determinant of severity of mitral stenosis? Okay, baby in PICU, Ijaz Ilahi, that's again an input. Then it is suprapubic aspiration. Then we don't take midstream sample. Ijaz, do let me know in the comments right now if it was like suprapubic aspiration given, because babies in PICU, then we can't take a midstream sample in a patient. Yes, supra. Yeah, okay. Manoj commented there. Yeah, it is suprapubic aspiration, guys. Then it is not a midstream sample. वो तो adults के लिए होता है। बच्चों में suprapubic aspiration is the best method for calculation. Okay. हाँ जी, opening snap S2 gap. Like this is the answer to this question. I get the point. I'll add up that question here. In a PICU, you have to take a urine sample in a patient. So what is the methodology to be used? So urine sample in children, it's always a suprapubic aspiration. The second thing is how do you determine the severity of mitral stenosis? Come what may, what will happen is the opening छोटा हो जाएगा तो टाइम ज़्यादा लगेगा, तो S2 और ओपनिंग स्नैप का जो गैप है ये लेस हो जाता है। मर्मर्स वाला वीडियो जो है उसके कीवर्ड में ये स्टेटमेंट मेंशन्ड है कि भाई जो मर्मर की सेवेरिटी है, जब वो ड्यूरेशन इंक्रीज हो जाएगी तो यू विल नोटिस दैट द मर्मर विल बिकम लॉन्गर। एंड व्हेन द मर्मर विल बिकम लॉन्गर तो ये जो गैप है ना ये कम हो जाता है। S2 और ओपनिंग स्नैप के बीच का जो गैप है आप देख रहे हो, दिस गैप इज बिकमिंग रिलेटिवली लेस। दैट इज द मेन डिटर्मिनेंट ऑफ सेवेरिटी ऑफ mitral stenosis। की वर्ड मैंने बोला, ड्यूरेशन और सेवेरिटी ऑफ mitral stenosis इज ईदर द लेंथ ऑफ द मर्मर और इनवर्सली रिलेटेड टू S2 ओपनिंग स्नैप गैप। ये जो दिखाई गई है लाइन, दिस इज द ओपनिंग स्नैप, दैट इज द मेन डिटर्मिनेंट ऑफ mitral stenosis का सिवेरिटी। बाकी सारी चीजें एक तरफ, और लाउड P2, लाउड S1, नैरो स्प्लिट S1, कुछ भी लिख दे उससे फर्क ही नहीं पड़ता है। इट इज ऑलवेज गोना बी द मेजॉरिटी ऑफ लाइक द एस्पेक्ट्स टू बी रिमेंबर्ड इज कि वो मरमर का लेंथ जो है वो इंक्रीज हो जाता है। हाँ जी, हाँ जी, हाँ जी। सॉफ्ट S1 नहीं होता बच्चे। सॉफ्ट S1 तो फिर वो कैल्सिफिकेशन बताएगा ना। इफ इट इज गोना बी, इसको अगर मैं लाउड की जगह पे सॉफ्ट भी कर दूं तो सॉफ्ट S1 क्या बताता है? तो सॉफ्ट S1 इंडिकेट्स कैल्सिफिकेशन ऑफ द mitral valve. It does not indicate regarding the severity part. Yeah, S2 opening snap gap is the best possible answer for this one. Opening snap in one and S2 opening snap in one. Okay, got it. Opening snap in one and S2 opening snap gap in the second one. The answer is still the same, S2 opening snap gap. यहाँ पे आप देख रहे हो ये जो गैप था वो पहले से कम हो जाता है because of the increase in the length of the answer. So yeah, Alok, you are right in that particular statement. Murmurs में से ना Graham steel murmur and S2 opening snap gap. These are like the first 30 minutes that are highlighted. Okay, decrease in this gap is, if he's mentioned the decrease, it becomes even much more comfortable for the answer in this case. Okay, जी. Moving to the next one, we are having a patient with NSRका having proteinuria 4.5 grams per day. ये थोड़ा clarify करना, मतलब साथ में हेमोचूरिया था या only proteinuria था? And then any biopsy finding was given in the question or whether biopsy was not given. Absence of second heart sound हो सकता है बच्चे, but answer will still be S2 opening snap gap. That's the determinant of mitral stenosis. Okay, so there is only proteinuria given in the question. Any biopsy, adult versus child, can you comment on that one? No, no, yeah, yeah. Okay, 18-year-old person, fine. So there can be two possibilities. Either the person is having focal segmental glomerulosclerosis or it can be minimal chain disease. In both the situations, there was no mention of any biopsy. The first line treatment that would be given in these patients would be steroids. Okay, prednisolone लिखा था. Okay, fine. Albumin in the option, ये एक बारी mention करना. Hyperlipidemia. Okay, the question had described hyperlipidemia. So essentials or diagnosis बता रहा है ना. So hyperlipidemia was present. Albumin in the patient was less. Yes, hypoalbuminemia is given in the question. Got it, got it, got it. That is triad ना. Basically वो पहले तो nephrotic syndrome के essentials और diagnosis satisfy कर रहा है ना. That is gonna be hyperlipidemia. That is why the cholesterol values are elevated. I get the point. If you read the first 6 lines of nephrotic syndrome, that is where this is highlighted कि भी nephrotic में proteinuria होता है, serum albumin कम हो जाता है and hyperlipidemia would be present. Okay. IV albumin, okay. Yeah, albumin therapy in the patient, intravenous albumin. Fine, get it. उस फायदा नहीं ना, दो जितना भी देंगे एल्ब्यूमिन निकल जाएगा, किडनी तो खराब होगी, तो वो फिल्टर ही खराब हो गया, तो जो भी देंगे वो सब निकल जाता है. सो दैट इज व्हाई लाइक देयर इज नो पॉइंट ऑफ गिविंग आईवी एल्ब्यूमिन इन दिस केस. Yes, if it is resistant to steroid, then we will add other agents like cyclophosphamide. Albumin, I get the point, Sagar. That is like albumin will not work because, as I said, that it will nikal jayega. Okay. Moving to the next one, alcoholic patient presents with gum bleeding and then on examination, delayed wound healing and corkscrew hair is noted. Doctor, since I think your comment GPK came late, I just want to highlight thalassemia minor के ना कोई symptom ही नहीं होते हैं. If you have thalassemia minor in the question, then it does not cause any manifestations, no? Okay, so this would be vitamin C because of gum bleeding and corkscrew hair. That's one of the characteristic. ये word था क्या corkscrew? ये एक बार mention करना. Corkscrew gum bleeding वाला हो गया. बस मुझे ये जानना है कि इसमें corkscrew present था या नहीं था. Okay, so that makes it easier for us to come to the conclusion. Patient presents with unilateral throbbing headache, photophobia. मतलब मुझे तो बोलने की भी जरूरत नहीं है. सुमाट्रिप्टन, मतलब इससे इजी क्या करेगा. Okay, corkscrew was given. Okay, so this makes answer as migraine, unilateral headache. तो you were like champions. फटाफट फटाफट से marks obtain करने वाली है ये वाले तो questions. Okay, pound symptoms were present. Patient presents with difficulty in ingesting liquids more than solids. That would make in favor of female patients. So I'll think in terms of AHLS cardia, and that will rule out option number A in this particular case. And considering that there is gonna be cardia, rat tail appearance or bird beak is the features that would be seen here. I mean, you cannot differentiate. These are like very subjective terms. Actually, it is like a very smooth tapering that is present. Now, whether some people want to call it a tail of a rat or some people want to call it a bird beak is okay. Smooth filling defect and irregular filling defect. So, doctor, this would be like a smooth filling defect. Okay. So I'll add the word there. This would be a smooth filling defect. That's the main aspect. As I said, I mean, it's not the subjective word. It's not the rat tail that clear that is gonna make the diagnosis. It is smooth versus irregular filling defect. Yes, I get the point. Okay. In cancer, it will be irregular filling defect. So that's how we differentiate basically. So I'm very sure the radiologist would have discussed this question as well, and you guys are sorted for this one. String sign is for Crohn's and apple core is for colon cancer. So the remaining options can be present. Okay, moving to the next one. We are having a patient on pneumonia who's developing a pleural effusion. So this would be a parapneumonic effusion, which would make it an exudate. And we then have to apply the Light's criteria in this question. What should we mark between rat tail and smooth? Smooth filling defect, Lord. We have to answer it as a smooth filling defect. The answer is not, we don't say rat tail then we say smooth filling defect. That's the key aspect. 5 and 7. Afferent is, corneal reflex is afferent is 5 and efferent is gonna be the 7th nerve. हमेशा ऐसे लिखते हैं ना, एक afferent होता है, एक efferent होता है. तो 5 नंबर और 7 नंबर ऐसे लिखते हैं. तो corneal reflex का afferent होता है trigeminal, sensory of the cornea. Efferent is gonna be the 7th nerve. Yes, okay, Alok, you are right in this one. Exudate is present. Exudate में ना सारी values more than होती हैं. It is more than 0.5, it is more than 0.6. यहाँ पे less than है. सारे values less than है. Yes, R3, you are right. It is a smooth filling defect. That is perfectly fine. So there were two separate ones. I got it, doc. This is smooth filling defect and a rat tail. Both are given in the options. Answer is a smooth filling defect. It is not to be given as a rat tail. Then rat tail is what you go in favor of a carcinoma esophagus. It's a smooth filling defect. Mayuri, the correct answer is suprapubic aspiration for the question that I mentioned. Smooth filling defect is, if it is given, then it is the correct answer. Lord, you perfectly spot on in this one. Corneal reflex question is what I've sorted out before you. And for the next question, you have to figure out that if it is exuded, the values have to be more. Here, the values are going to be less. So the answer by exclusion would be option number C. That is going to be pleural fluid less than 7.2. Yash, can you quickly comment about what was the question on paroxysmal nocturnal dyspnea? Yes, Sudhavna, if there was no mention, then I'm okay with it. Otherwise, if you say smooth filling versus irregular filling defect, तो HL as a cardiac तो smooth होता है ना बच्चे, because irregular filling defect तो मतलब वो cauliform growth है, तो it will not have a very, it will always have a irregular filling. Okay, fine. Chronic smoker wakes 3 to 4 hours in the middle of night and goes to the window. Okay, fine. That is, yeah, PND. Patient gets up at night, opens the window and grabs for bread. That would be answered as PND. जी, fine. So for this one, guys, we just have to work out exudate होगा तो values more होनी चाहिए, considering 3 values are less. So the answer would be given as option number C. Your child had a mitral valve defect, wakes up at night, goes to the window and pants for breath. That would be PND. I'll mention this question in short here at the moment, just for my reference. Mitral valve defect given in a question. It's gonna be child. He gets nocturnal awakening. He goes to the window and then he pants for breath. And you were spot on in picking that up. That's gonna be answered as PND, paroxysmal nocturnal dyspnea. Yes, and wakes up after a couple of wakes up after a time. So I'll put that, doctor. Okay. The next question is from Advanced Cardiac Life Support. I'm not sure about the image. Was he mentioned? Yeah, Deepu, I think I sorted that midstream wala. It's not midstream, it is suprapubic aspiration. Ya to IHC, in hospital cardiac arrest or out of hospital cardiac arrest was mentioned. And I think this is already discussed, so then it cannot be an issue. Yep. या दिस वुड बी रिकवरी ओनली. वो दो आदमी साथ साथ खड़े हैं तो रिकवरी होगा भाई. वो तो मैं तो अगर ये फोटो दे रखी थी दो आदमी साथ साथ खड़े, तो इंग्लिश से लगाना ना कि भाई उसको थोड़ा सपोर्ट प्रेजेंट कर रहे हैं. तो आई मीन द वे टू सॉल्व दिस वाज टू यूज हिज इंग्लिश अगेंस्ट योर इंग्लिश. वो भी ब्रिटिश इंग्लिश दे रहा है, फोटो से सॉल्व कर लो. Yeah, I got it. In Advanced Cardiac Life Support 2020 update, what is the new thing that is added? Answer is recovery in a sense कि एक 6 पॉइंट उसने पोस्ट कार्डियक अरेस्ट केयर के बाद में रिकवरी बोल रहा है. ओके, fine. Which of the following is not a feature of Pancoast tumor? Any history given in this one with respect to lung cancer? Pancoast tumor will result in Horner syndrome. And Horner syndrome can be remembered as a mnemonic by the name of Punjabi meal or perfect meal, whichever way you want to remember it. And in that Punjabi meal, what you get is enophthalmos and not exophthalmos. So that would make it easier for us. It is meiosis, enophthalmos, anhydrosis, and loss of ciliospinal reflex. The remaining things are okay. Punjabi Bill P would mean ptosis, anhydrosis, loss of ciliospinal reflex. So the answer in this case is exophthalmos. Anybody has a different opinion, let me know. Okay. Okay, Nitin Gupta, you put up a question. I'll surely revert back to you. Drop me a mail at marwahmedicine@gmail.com. I'll be able to quickly answer that. Okay, fine. Next is again a one-liner. Chvostok sign is seen in. Uh, yes, guys. हाइपोकैल्सीमिया है मतलब मुझे पता है मुझे तो सिर्फ ऑप्शन जानने हैं इस वाले में वन अबाउट कोविड स्क्रीनिंग ओके एलिजा एंड रियल टाइम पीसीआर ओके or doc real time PCR only no initially about COVID it would be real time PCR only that would be done no social support तो नहीं होगा it would be recovery and not social support okay okay जी fine so I think this was a easy one formic acid yeah Izaz Ilahi you are right this is methyl alcohol poisoning visual difficulty after drinking from a local shop I get the point I'll just jot it down quickly I did not have that question visual acuity after drinking from a local shop and it is formaldehyde that's gonna be formic acid basically which is a derivative of formaldehyde because this would be a feature of methyl alcohol poisoning कोई ना कोई सपोर्ट कर देना उसको सपोर्ट कर देना then is patient with TB in the AIDS started on antiretroviral therapy या फॉर्मिक एसिड इज द डेरिवेटिव ना मिथाइल कोल टूटता है तो कल्ट निमोनिक पे समझाया मैंने ये कल्ट कल्ट निमोनिक इज फॉर मेटाबॉलिक एसिडोसिस ना उसमें टॉक्सिन्स में बताया कि मिथाइल कोल पीने से फॉर्मेल्डिहाइड बनता है फॉर्मिक एसिड बनता है एंड दैट फॉर्मिक एसिड कॉजेज द एन्सेफेलोपैथी एंड कंट्रीब्यूट्स टू डेथ इन द पेशेंट yeah mains would be coming very soon doctor in our next edition we are focusing on the main videos in Hindi only okay next is patients of tuberculosis and AIDS intern is preparing a patient intubated later patient developed breathing difficulty तो डॉक्टर वो ट्यूब जो है ना वो एक लंग में चली गई है एक साइड की सिलेक्टिव इंट्यूबेशन ऑफ वन लंग ना बिकॉज ब्रेथ साउंड इज हर्ड ऑन ओनली वन साइड प्रियंका you have a very good question it's more of anesthesia but point is why is he having a breathing difficulties because the tube went into the right bronchus so the left lung is not getting ventilated that is why breath sound is coming on one basic side Okay. Yeah, Shubham, in that question that you put up on methyl coal poisoning, na, the point is if he says what is the metabolite, then answer is not methanol, na, because methanol is metabolized to produce formic acid. So it is if he says metabolite, then the answer would be given as metabolite is formic acid. Okay. QT prolongation is hypocalcemia. Okay, that is a question that I was missing. I was looking for that. QT prolongation with hypocalcemia. Yeah, endobronchial intubation. Yeah, Alok has given that correct statement for that question. But anyway, I hope Dr. Priyanka that is clear that the tube वो एक ही लंग में चलेगी तो तभी उसको सांस लेने में दिक्कत मतलब उसको SpO2 ड्रॉप कर रहा है दैट इज बिकॉज ऑफ द एंडोब्रोंकियल इंट्यूबेशन सो फॉल्टी नहीं बोलेंगे फॉल्टी तो मतलब हुआ कि वो ईसोफेगस में चलेगी फिर ब्रेथ साउंड्स नहीं आते ना The question mentioned breath sounds on one particular side. If he says that breath sounds are not heard in the chest, then you will say faulty intubation in a patient. But if he says breath sounds are heard on only one side, then the right bronchus is more in alignment now. So the tube goes into the right side in that particular case. Okay, so in this particular question, patient is started on antiretroviral therapy और उसके टीबी के symptoms वर्सन हो रहे हैं इसको हम आयरिस बोलते हैं immune reconstitution inflammatory syndrome and this is like a standard statement that has already been taught कि भाई पहले टीबी की दवाई देना है and after 2 weeks it is antiretroviral therapy and अगर किसी डॉक्टर साहब ने उल्टा कर दिया by mistake then that is worsening of symptoms of tuberculosis that would be occurring इसको हम आयरिस बोलते हैं वो इम्यूनिटी बढ़ जाएगी साइटोकाइंस बनेंगे so that is the reason or the rationale behind the answer to this question. Okay. या पैराडॉक्सिकल इम्यून रिस्पॉन्स ही बोलेंगे डॉक्टर उसको, या दिस कैन बी रिटन एज पैराडॉक्सिकल इम्यून रिस्पॉन्स ऑल्सो, दैट इज द पैराडॉक्सिकल इम्यूनिटी का मतलब ही यही है ना कि भाई नॉर्मली तो इम्यूनिटी शुड किल द इन्फेक्शन, हेयर इम्यूनिटी इज कॉजिंग वर्सनिंग ऑफ सिम्टम्स ऑफ द डिजीज, दैट इज वाई वी कॉलिंग इट अ पैराडॉक्सिकल इम्यून रिस्पॉन्स। ओके जी। ए वेव इन जेवीपी इज एट्रल कॉन्ट्रैक्शन, ये तो मतलब नींद से जाग के भी आप लोग कर लोगे। Dr. Melvin, I just want to know management of hypercalcemia, like what were the options, if you can just quickly mention it, then it would become relatively easier for. Okay. Next is Alok, I love your spirit. Diabetic patient presents with fatal edema and shortness of breath due to heart failure. Which drug shows a cardiorenal benefit? I'll let you guys do the talking for this one. That's, I think, that's the last one that I have. Yes, that's the last one that I have for this slide. So I have about 35 questions at the moment that I've discussed at the moment. That would be bigonides. Okay, fine. I think there was bigonides. Drug category का नाम दे दिया था वो, sitagliptin दिया होगा. Okay, okay. SGLT2 inhibitor. Okay. Ectopic spleen. Okay, guys. I think that would be omentum, right? And carcinoid appendix. Normal saline is the first one for management. I'll put it there. Hypercalcemia. What is the first line management? It is normal saline with furosemide because we want to decrease the serum calcium values. Okay, alendronate, glucose. Okay. If he says what is first line management, it is normal saline, and otherwise it is bisphosphonates that would be used. That's the drug of choice for this patient. Yeah, I got it. Sensei, that I got it. This is like sulfonylurea. So glipizide नहीं लिखा. बात तो एक ही है ना बच्चे, मतलब sulfonylurea बोलो या glipizide बोलो, it will make it the same. Okay, and calcitonin. Okay, Aman gave a good input. So yes, guys, we are arriving at this question of hypercalcemia. Let me know whether it was first line management, whether it was treatment of choice in this question, guys. Okay, calcium more than 14, so that makes it vulnerable for cardiac arrest. Treatment of choice, Dr. Bisphosphonates. If it is treatment of choice, then it is bisphosphonates to be given to the patient. Ideally, we would be giving intravenous bisphosphonates. That would be in the form of ibandronate or zoledronate. But normal saline is always the first line management, never the treatment of choice. If you listen to the electrolytes discussion, this has been highlighted. I mean, I've discussed all the electrolytes together: hyperkalemia, hypocalcemia, hypercalcemia, and all of them all together, right? I have spoken regarding treatment of choice for hypercalcemia as bisphosphonates. So guys, this is what I have at this particular point of time. This would be CST. IV fluid बच्चे first line management होगा ना? Yes. If it is first line management, in pregnancy, loud S1 cannot, it can be normal ना? जोलेंड्रोनेट बिसफॉस्फोनेट करते हैं ना बच्चे, इट इज बेसिकली आपको तो यहाँ पे कोई सा भी बिसफॉस्फोनेट दिया हुआ, इट कैन बी एनी बिसफॉस्फोनेट दैट इज गिवन. The treatment of choice for hypercalcemia is always bisphosphonates because they will send calcium inside the bone. And if he says first line management, then it is normal saline that should be given. Yeah, in the question about increasing the dose of metformin, no, doc, we will not increase the dose of metformin. HbA1c was 8.5. I think the pharmacologist discussed it. HbA1c was 8.5 and it decreased to 7.4. That was the question, and still the blood sugar of the patient is 140. So what will you do in this particular case? So continue metformin because HbA1c, जो metformin होता है, it causes 2 percentage points decrease in the value of HbA1c in the patient. So we'll have to continue the same management in this particular case. Yeah, in pregnancy, there is some MDM, that would be mitral stenosis, doctor. Pregnancy, MDM would be mitral stenosis. Okay. Let me know, guys. Let me know. Yeah, I sorted that, Kasim. The next line management would be continue the same management there. But I think those ifs and bits that I mentioned, they would be around about 4 that I think I missed. I put them out, I rotted them in the data at the moment. I have like 35 on my slide at the moment. That would be around about 4 which I have written here at the moment before. But once you get them in the app, they'll be all like 39 of them put all together. So CKD with CHF, yes, the doctor would be same Dr. Yishan. That is the question on diabetes that I mentioned. I think the pharmacologist spoke about it. It is same metformin dose that is to be given, not upgrading the dose of metformin, because metformin takes about 3 months for the value of HbA1c to fall by approximately 2 percentage point. So I think that if we continue with the same dose of metformin, patient is good to go for this one. Okay, the SAC question. That is, I think, that's very much there. Give me a second. I think we are missing a SAC question. Yes, 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 yes. We missed a couple of them, guys. Here they are. That is what I was saying. Yeah, 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 yeah. Good, good, good. You pointed out. We should not have missed that. Patient with SAG. Okay, good. You mentioned that. SAG more than 1.1. Okay. Patient of liver cirrhosis with breathing difficulty. There are two important questions, guys. Good you raised that point. SAC question is very much there. Patient with liver cirrhosis and presents with breathing difficulty due to massive ascites, and he says, what is the incorrect statement? CKD with heart failure, and answer is SGPT. Yeah, doctor, exploring body. Yeah, SGLT2 inhibitors. No, because in heart failure, like if you listen to LLR plus, LRR plus, or listen to the discussion that I took very much in the end also on my channel also, in heart failure chronic में बताया ना कि भाई SGLT2 inhibitors are used because they have been found to be renoprotective. Smooth filling is simple, is what I mentioned. Okay. Cola color बच्चे नहीं हो सकता because cola color is something which is always seen with hematuria. If it's the red urine, then it is gonna be myoglobinuria. Yeah, what is the wrong statement in this one? Okay, SAG is less than 1, ascitic fluid is more than 1. Okay, fine, got it, got it. No, it is not less than 1.1 na bache. It is gonna be always, SAG is always gonna be more than 1.1, and ascitic fluid protein is gonna be more than 2.5. That is gonna be the correct statement in this particular case. Checking this is fine. Secondary hyperaldosteronism is fine, but the value in this case would not be less than 1.1. Whatever happens, no, portal hypertension may, there would always be SAG values more than 1.1 to be mentioned. Okay. Yeah, the wrong statement is what I have. Incorrect की जगह पे wrong लिख लो यार. It is the same thing, right? Whether I say wrong statement or what is the incorrect statement also. Okay. Yeah, any value which is less than 1.1 basically tells us that there would be some kind of an infection present in the case. So it could be TB, it could be due to any other cause. I mean, causes of this can be multiple. No, he can write it as tuberculosis, he can mention as any other case. The point is SAG values, anything is gonna be. The correct statement is gonna be option number A, and the incorrect statement in this case will be option number B. Radiation pneumonia, it just that was mastectomy and then a radiation pneumonia. Lights criteria I have already discussed, man. Lights criteria, the previous question that we discussed for this one was lights criteria only. Correct statement is option number A, and the most appropriate statement is option number A, and the wrong statement in this is option number B. Okay, coming to the next one. Patient had a fight with Sanskriti, can you just let me know tuberculosis was written as an option in this question? Yeah, absolutely. It's not pneumonia, doctor. It would be pneumonitis. No, there would be fibrosis in the lung. That's what he's trying to say. GCS calculation, I think the answer was either 11 or 12. I think the surgeon talked about that question where there was the patient was able to localize the pain. The GCS question, if I recall, it was regarding patient is able to localize the pain. That will make M5. And then I think eye opening on pain was present. That was making it 7. And patient was confused also. So I think it was working out to in a range of about 11 or 12, depending on the options in the question. Yeah, I think 12 was the most appropriate answer in this question. There was no 9, I think it was 5, 7, 11, and 12. And because the patient was able to localize the pain, the M value was coming out to be 5. So GCS, I think the surgeon would have discussed it. The value would turn out to be 12 in that case. Yeah, Mohit, you are spot on that. Yeah, absolutely. नहीं 10 तो नहीं बनेगा ना यार, 5 नंबर तो वही हो गया ना यार तुम्हारा, 5 नंबर का तो लोकलाइजिंग पेन ही हो गया, और उसके बाद 2 नंबर में ही इज एबल टू लाइक ओपन हिज आईज, आई थिंक इन रिस्पॉन्स टू कमांड था। Okay. Fine, guys. I need options for that, right? But I think the way I could check out in the actual chat that came to me, the answer was turning out to be round about 12 in the question. R3, you need to let me know what are the options then, in case you can quickly comment on that. That would be absolutely 12. Okay. Chalo, great. लेट्स मूव ऑन टू द नेक्स्ट वन. आई थिंक जीसीएस वाले के पास तो मेरे पास ऑप्शन ही नहीं है. हम क्वेश्चन तो दूसरा डिस्कस कर रहे हैं कि बाउंसर ने मारा, छाती में मुक्का मारा होगा तो रिब्स टूट गए होंगे उसके. एंड आफ्टर दैट देर इज हाइपर रेजोनेंस एंड एब्सेंट ब्रेथ साउंड्स इन अ पेशेंट. चेस्ट एक्सरे शोज अ ट्रेकियल शिफ्ट. Yeah, the Sanskrit you write in that because that is the incorrect statement. No? The question was like regarding what is wrong about it. So if we are talking about liver cirrhosis, then the SAG value and tuberculosis would not gel together. Okay. Infants tak, right up to infancy tak, it is always infants kya, even small babies also, toddlers also, it is a suprapubic aspiration only that will be using. Only in a older child, like I think more than 7 years of age or more than 10 years of age, you can check your pediatrics notes for that. Then only midstream sample concept can be explained. Okay, ji. Tension pneumothorax versus traumatic pneumothorax. Okay, I'll first answer it as traumatic pneumothorax only. Then somebody told me that okay, fine. Still collapse of the lung. Okay, fine. Collapse of the lung. So that makes the answer easier for us. It would be traumatic pneumothorax, considering that person is suffering from hyperresonance. Okay, one option was lower lobe consolidation. Okay. Fine, guys. The correct answer for this one will turn out to be traumatic pneumothorax. One question of FINA. Shivam, I spoke about it. Urine osmolality more than 500 is where the pre-renal variety would be present. Okay, infrarenal. Sorry, infraclavicular. Hyperresonance was given in the question. See, if I don't have between tension and traumatic, I would have answered it as tension pneumothorax because patient is collapsing now. That is why. If blood pressure is crashing, there is no mention of blood pressure, but patient collapse kar gaya na. So patient collapsing indicates that the blood pressure of the patient would have crashed in those particular point of time. Okay, shots, that's a good one. What's the first defense mechanism for hypoglycemia when the sugar goes to 70 to 80? Cortisol, first would be glucagon rising, and then would be cortisol and catecholamines rising. Shots, can you just quickly comment on what are the options? Did they have glucagon and cortisol in the options? Witty doctor, resonance we don't get in collapse. Collapse में तो dullness आ जाएगी ना. It is hyperresonance is always air present. Okay, so Ijaz mentioned that glucagon would be the first response, doctor. That is what will happen now. Glucagon is the answer. First thing is glucagon. I think यार डायबिटीज में मैंने ये चीज पढ़ाई है कि जैसे शुगर 70 के नीचे जाती है तो द फर्स्ट थिंग दैट हैपेंस इज इंसुलिन प्रोडक्शन विल स्टॉप एंड ग्लूकेगॉन प्रोडक्शन विल स्टार्ट बिकॉज ग्लूकेगॉन इज द काउंटर रेगुलेटरी हार्मोन सो alpha cells will come into picture. So the first thing that happens when blood sugar begins to fall is rise of glucagon in the patient, and then subsequently it is catecholamines and cortisol that will come up. Okay, Mubarak, I don't think so. They would have put tension and traumatic pneumothorax both in a question. If you force me to put those two options, then I'll answer that as tension pneumothorax, considering the fact that the patient has collapsed, and collapse would mean that the blood pressure of the patient would have been affected. Okay, fine, guys. I think these were two questions that got skipped in between due to some, I would say, oversight on my part. But I have like about 35 at the moment discussed, and then there are about 3 or 4 that I'll be incorporating in the final discussion. So it was, yeah, it will not be primary pneumothorax ना बच्चे. Primary pneumothorax तो is seen with rupture of bulla. वो COPD का जो बुल्ला होता है ना वो फट जाता है ना, उसकी वजह से मारा किसी को तो ट्रॉमेटिक pneumothorax या टेंशन pneumothorax ही बनेगा. Okay, Ji. Fine, guys. So we are sorted as far as today's discussion is concerned. Thank you so much for joining in. I honestly did not expect that. I thought okay, everybody would be chilling at the moment, so I'll be talking to myself. But hats off to your dedications that you guys came in and dropped in your answers, your doubt, your experiences in the chat below. And as I say, I mean, learning never stops. we keep on upgrading ourselves on a daily basis. So a lot of people will talk negative. No, there is no point of listening to recall. कोई फायदा नहीं होता and everything. But I think that when we listen to it, we tend to realize some good things about us, some things that okay, our mind did not click. So that makes us more positive about our daily approach. So that is what I would do at if I'm at your place. I'll try to improvise. I'll keep on learning on a regular basis so that I can upgrade and I can do better things as compared to this. Bell's palsy, doctor, I've already handled there. ओके जी, थैंक यू सो मच गाइस। मेरी दुआ आपके साथ है, सबके साथ में, मेरे प्रेयर्स आप सबके साथ में हैं। एंड आई विश वंस द रिजल्ट कम्स आई विल बी लिसनिंग टू ऑल द happy stories. So till then guys, this is those last few days of your life when you get to enjoy. Once you start joining your hospitals, तो भाई जिंदगी फिर तो काम करते निकल जाती है। लोग पीपल इन इंडिया डिबेटिंग 70 आवर वीक, 90 आवर पर वीक। इंडिया वाले कैसे बोल रहे हो 90 आवर्स पर वीक, 70 आवर्स पर वीक कैसे काम करेंगे? हम डॉक्टर्स को देखो यार, हम तो कंप्लेन ही नहीं करते। मतलब मतलब आई एम नॉट सपोर्टिंग दैट, इट्स टोटली रॉन्ग, इतने नंबर ऑफ आवर्स शुड नेवर बी हैपनिंग, बट हम डॉक्टर्स लोग तो यार, आई मीन वी हैव बीन डूइंग इट फॉर सच अ लॉन्ग पीरियड, हमने कभी शोर नहीं मचाया ऐसे, अनलाइक लाइक व्हाट ऑर्डिनरी पीपल आर डूइंग ऑन सोशल मीडिया. So yeah, I will be putting up much more questions guys subsequently. Thank you so much for once again joining here, and happy Makar Sankranti. Wherever you are in India, enjoy your these few days, and then subsequently, once the result comes, I'd be glad to interact with you once again. At the moment, chill. Don't bother about anything. Try to enjoy your life. Whether you what recalls don't matter, man. They are like they don't matter from the perspective that I should not take it to the heart. I can get some right, some wrong. Don't take it to the heart that okay, I got 180, so I am like super great. If I'm like getting 145, I'm like I'm not nowhere. It's never like that because variation of nuances can be there in the recalls as well, because I did not sit for the paper, right? It's like you guys who sat for the paper, and based on the inputs that you guys provided, I was able to give a final input with respect to what I think is the wise thing to do in an exam. And I tried to be fast in my interpretations as well. I tried to put stress on my brain so that I had to give an answer within 1 minute. So I was trying to replicate what you guys would have gone through in the actual paper. So God bless you guys. Take care. All 300 subsequently would be compiled in the app, doctor. Like you don't need to bother about it. We are in the process of doing that, and very sure, like in the app, in the subject-wise discussion, you will be getting all the questions there. Happy Lodi, happy Makar Sankranti. It was really nice interacting with you guys.